Oh, somebody has black labs.
Okay, well, hello everybody. Thanks for coming to another session. If this is your first session, then welcome. Today we have Dr. Krohn, so I'm just gonna let her take it away. But also, if you have questions that you wanted her to answer, you can put them in the chat, or you can click like the feature and unmute yourself, and then also ask the question that way too. Either way works. So I'll hand it over to her.
Hi. So I'm Dr. Krohn. I'm an internal medicine and pediatrics hospitalist. So I work at the U and doing just hospital medicine, either with adults or with kids. So I'm on both sides of the river. I've been here for about 3 years in this position. In addition to my clinical time, I teach in the first year medical school, as well as a couple of electives in the third and fourth year. And I teach a global medicine, global health course for practicing providers online. Going through a lot of different things. So we work on how to best interact with immigrants and refugees and how to provide competent cross-cultural care, how to talk about end of life and dying across cultures, how to work with interpreters, as well as things like how to deal with illnesses that we don't necessarily see in Minnesota all the time, like malaria and dengue and things of that sort. My path to getting here, I'm from northern Minnesota originally. I grew up in Cloquet, which if you don't know is near Duluth. And I hadn't really left Cloquet at all, lived in the same house till I went away to college. Somehow I always knew that I wanted to be a doc. I thought I wanted to be a surgeon. I'm not a surgeon now. And I did a lot of the sort of typical, check off the box sorts of things going through college. Once I got into medical school, I decided to take a couple of times where I would just pause and do sort of what I had wanted. So I want to encourage you that once you do get into medicine, you don't still have to just follow the path that everybody lays out for you. So I actually took my fourth year of medical school as 2 years instead of 1 year. And what I did during that time was I spent about 18 months studying outside of Minnesota. I spent 6 months working on a HIV and Cryptococcus research project in Uganda. I did some assisting with the clinical side, but as a medical student, I couldn't do tons on the clinical side. So I did a lot more in the environmental side, sort of doing geocaching. Like the goal of the research was try to figure out where in the environment was Cryptococcus coming from. So we went and got samples from all sorts of fun places. I spent 4 months in Brazil, in Curitiba, just studying on an infectious disease ward. The VA here has a partnership with one of the training centers in Curitiba, and there had been people from Curitiba who came every year as infectious disease fellows to Minnesota to study, but they never had somebody go back to Brazil. So they were very excited that I could speak Portuguese and I could actually just round with them. Of course, when I got there, my Portuguese wasn't nearly as good as it needed to be, and the secretary said I was that nice girl who sounded like Yoda. I sort of made sense, but not exactly. I spent 3 months working in studying in Ecuador, working on learning medical Spanish. I spent a little bit of time in Hawaii studying complementary alternative medicines, and I spent some time hiking over the Gila Wilderness, working on wilderness medicine and first aid. I think it was really wise to take the easiest year of med school twice, as opposed to one of the harder years. In residency, I again took time off. So in the middle of the 4-year residency, I stopped and I did a fellowship in global health and media, working on how to communicate difficult things like, I don't know, COVID, to regular people who don't pay attention to medical news all the time. With that, I worked with the World Health Organization in Southeast Asia Regional Office in New Delhi, which if you're not geography inclined, that is not in Southeast Asia, but South Asia, close enough. Politics gets everywhere in public health. I also worked at NBC News on the nightly news through that fellowship. I came back, I finished residency, and then when I finished, I worked as a pediatrician at the Center for International Health in Midway in St. Paul for a little while. Paid off as much as I could of loans, and then I went and volunteered through Health Frontiers in Laos, People's Democratic Republic. So there I was teaching in internal medicine and the pediatric residency programs. as well as helping them start an emergency medicine residency program. And I was there for 2 years and came back to Minnesota to have my son, who is now 2 years old. So that's like my long story. But without really any specifics, what sorts of things would you guys actually like to hear about? Or what questions do you guys have?
Hi, can you hear me?
Yes, Amanda.
Hi, so I guess my question would be like, what does a typical day consist of for you as a pediatrician, or I guess in your case, internal medicine?
Yeah, so my day, it totally varies. I like variety, so I'm not in the same spot. So on the peds side, I can work on a couple of different shifts if I'm in the hospital, and I'll be in the hospital generally for 7 days at a time. So if I'm on peds, then I go to the West Bank, usually to the purple Masonic Children's Hospital building, green in some lights, purple in others. There I generally work with resident teams. So all of the services have residents and medical students on them. And so the medical students and the residents all go see the patients, and I try and make sure I know everything that's going on with the patients without seeing them. And then we meet as a team, and we go to see people together where the medical student or resident will share what they learned. And I try really hard to stay silent and let the medical student or the resident talk through everything as best they can, and talk with the families and the patients and let them know sort of what the next plans are and address questions. But I'm always there if there's anything further that needs to happen, or any additional conversation that needs to happen. For the most part, when I'm on days, I'll head home on peds around a bit before around 5. I try to stay until after 3. So sometime between 4 and 5, I head home. Oh, so many good questions are showing up in the chat. If I'm in internal medicine, I can be on either a teaching or a non-teaching service. If I'm on a teaching service, it's sort of the same. Like I try to hide in my office and try to know everything on the computer before we go to round. And then on medicine, I may or may not go do bedside rounds with each of the patients. I may see the patient separately on my own. It sort of depends on the team, and also depends on how COVID is. Pre-COVID, I did a lot of bedside rounding regardless of whether it was medicine or peds. Post-COVID, I do less bedside rounding on medicine. If I'm on a non-resident service or non-teaching service, then like I get here and I start seeing patients first thing in the morning. And then I'm on a non-teaching service, it's basically in and out of patient rooms from 8 in the morning to 5 at night, and try to finish my notes at a reasonable hour. When I'm not teaching, when I'm not in the hospital, I can work from home for the most part. Sometimes there's meetings to go in for, other things depending on what I'm doing. Now with teaching from Zoom anyway, I can do that in my office. I'm gonna, if somebody else has a specific question, otherwise I'll turn to the questions in the chat.
I guess for me, sorry.
Yeah, go ahead, Amanda.
Okay, so because I'm strongly considering, so I'm my last year of undergrad, I want to be a pediatrician, but what would you say would be the biggest difference between being at a hospital and being either at your own, or maybe not your own, but like at a more clinic outpatient?
Yeah, so the biggest difference is that there are a couple of things. So one is the main thing is at the hospital, you don't tend to see people over a long period of time. So like the relationships that I had with my patients and when I was in clinic, like you would see a kid grow up. And like if I had stayed there, like the kids that I had when I had them as newborns, they would be like 5, 6, 7 years old now. And you really get to have relationships with families over time. That's something that I really value, that I know my family practice provider and have known her for over a decade at this point. And that's something that I do miss some in hospital medicine. Being at the U, I still sort of get that relationship sometimes. Unfortunately, it's because somebody has a really complicated health problems. And so they're frequently hospitalized, which isn't the ideal way to form long-term relationships with somebody. But at the same time, you do get a little bit of it. But those are the big differences, in my personal opinion.
That's what draws me more towards clinic, as you were saying, kind of seeing them through. So thank you.
No problem. I feel like part of it is how much adrenaline I need also. Like if I needed more adrenaline, I would probably do ICU or ER. That's just a little more adrenaline than I need in my life. So I'm at the hospitalist level. And I could see myself soon being happy in a clinic again. But I did find that I just needed a little more variety than I was getting in clinic. And that's part of why I'm, med peds and teaching and not settling down.
Is there maybe a half and half?
There are some people who do that. It is more common in medicine than in peds, in part because peds hospitalist positions are sort of high in demand. But there are some people who still do that. And if you're part of a practice that has that as a potential, you can change your mind and do it later. That's fair. That's very fair. It used to be standard that all pediatricians would do sometime in the hospital and sometime in clinic. And now it tends to be pretty divided. There are some groups that the only thing they do in the hospital is newborn rounding and seeing the babies.
Hello, Dr. Krohn. With your teaching that you do, is it just for residents, or do you also teach classes in like a medical school or undergraduate somewhere?
Right. That's harder to answer than it used to be. So a year ago, I taught for physicians and residents, and that was it. Since March, I've taught several medical student classes, and I'm now actually going to be continuing to teach a medical student class. We've also made a bunch of the teaching that we did online for practicing providers available for medical students as well. And we're working on trying to see if we can keep that up. And then this summer, I actually ran an internship program for some undergrad students when all of the internships stopped, because what I do is online education. And part of what I've been working on is trying to make things less sit there and watch somebody give a lecture to somebody else and answer a few questions, and more actual engaging game-like learning that still has real-world benefit. And to do that, what I did is I had a bunch of students who were like, I want to learn about this anyhow. I'm like, well, why don't I help you learn about onchocerciasis, which is known as river blindness, by giving you some and helping you create something with it. And then it's so much better. And then hopefully we can get this into an interactive thing that other people can use and learn. So newly I've been doing some undergrad stuff, but I had not exactly planned on that. It's sort of like people can't do their normal research. Everybody's had other stuff, and I do online stuff. So what can I do? And it actually worked out pretty well. So I'm probably going to try to do more of that in the future, but I don't know yet.
And just a quick follow-up to my question. How was the transition from just practicing, like coming out of med school, practicing, into going into a teaching position at the same time that you're practicing?
It was pretty straightforward. Part of being a resident is that you also teach the medical students that are on your team. So, and if you look back, the word doctor comes from the Greek word for teacher. So what we do is we teach our patients. Like if they don't understand what we tell them, they're not going to do it. So sort of constantly being in the mindset of how to convey information in a way that people actually remember it and then own it as their own. That's the same regardless of who the learner is.
Thank you.
No problem. So the first question I see up here was Nikki asking about what did I do in Hawaii, and could I speak more about the fellowship in medical communication? So in Hawaii, at that time, the University of Minnesota had a rotation in Hawaii that was on complementary alternative medicine. We spent some time at the so it was funded by Earl Bakken, who was the founder of Medtronic. And he helped build a hospital on the Big Island in Hawaii that tried to incorporate nature and other things into a healing setting. And so lots of skylights, lots of plants, that sort of thing, where you could still provide high-level hospital-type care. So that we did some of that. We studied with a naturopath and with chiropractors, as well as traditional Hawaiian healers, which I thought was the most interesting part of that, as well as some Chinese herbalists. So those things were pretty cool. There are some aspects of that I use in my work now, but a lot of it is knowing the other things that other people are doing. Because so many people engage in complementary alternative medicines in some way, shape, or form. I end up recommending a lot of exercise, PT, OT, acupuncture, massage, those sorts of things on a very regular basis for symptomatic relief and for helping people sort of own their health. But I also walked away from it just acknowledging how expensive these things are and how so many of my patients, when I worked at the Center for National Health, wouldn't necessarily have access to those, even more so than they wouldn't have access to Western medicine. And so trying to have conversations about what is appropriate and what is worth investing most with families is acknowledging all the other things that they hear that are out there and being able to talk knowledgeably about them. I did have one patient who was from Vietnam originally and would go back to Vietnam every winter, where she could actually afford acupuncture 5 days a week. And so she would do acupuncture for 5 days a week, and her back pain, her osteoarthritis, her ability to move would improve drastically. And then she'd come back to Minnesota for the next 9 months and slowly get worse, and then go back to Vietnam again for the winter. And it's like, I wish I could do acupuncture here in the way that it's been studied. The Medical Communications Fellowship was in my residency years. There are now 2 of those fellowships that I know of. So the one that I did, which was through Stanford, and there's one through Columbia. And the biggest thing is about trying to get physicians and scientists to just be able to talk like normal people. We learn jargon, like that's what we spend all of our time in med school doing. And often that puts in a huge barrier about how to just talk to normal people, because we can't get out of our own medicalese language. And trying to turn back to like what really resonates with people, which often isn't statistics. It's often the stories and the experiences that people have as individuals. And often that's what people go into medicine for in the first place, is being able to talk to another person, not necessarily because we love all of the stats and the other things. I'm not certain I answered your question fully there, Nikki. And I don't see Nikki anymore. Okay.
So sorry, you did answer my question. I really appreciated that. I was particularly interested because I actually am living in Hawaii right now. So that's why I was so curious about that. And you just mentioned it and I had to say something. What is the hospital on the Big Island, if you don't mind me asking?
Oh, yeah, it's now been a while ago.
Oh, that's okay. You can message into the chat at a later point if you remember, but I'll do my own research. I really, you mentioned a doctor you worked with. Do you remember, would you mind mentioning his name again?
So in Hawaii?
Yes, sorry about that.
No problem. So the person who I mentioned was not a doctor. It was Earl Bakken, the founder of Medtronic. So he's the one who funded for students to be able to train in complementary and alternative medicines, and who helped fund the hospital. Oh, so wow. If you were to look up Earl Bakken's hospital on the Big Island, I'm certain you'd be able to.
That's exactly what I'll Google. Thank you so much. And I am definitely interested in looking at the Medical Communication Fellowship during residency.
Cool. And it's one that's available to people as soon as they're medical students. So you can do it as a medical student, as a resident, or afterwards as a practicing doc.
Oh, wow. Thank you.
No problem. Next question? Or I'll keep going down the chat. Increases in diseases that used to be rare in the US due to vaccine hesitancy. I mean, yes. When I started medical school, the idea of having measles in Minnesota was just not comprehensible. The assumption was that nobody in my generation of physicians would see measles or chickenpox or polio. And I've seen all of those. I mean, I haven't seen polio in the US, but I've still seen a lot of vaccine preventable illnesses. Vitamin K is one that's becoming more and more of an issue. So we specifically give newborn babies an injection of vitamin K because often they're a little bit deficient in vitamin K when they're born. And one of the biggest reasons for early death in kids was that as they would be born, the trauma of being born would cause them to bleed. And now we have more people who are refusing a vitamin K shot, and we have more people who have kids who have bleeds into their brain and irreparable damage. Like once it happens, there's nothing we can do. So yes, lots of differences because of vaccine hesitancy.
I have a follow-up question for that. How is the medical community dealing with vaccine hesitancy? Is that like, I know that they're probably getting talked about, but like, what are some specific things that like the medicine's doing?
So that's one of the big reasons why people are trying to learn how to speak English again and not just medical jargon. There's a lot of people who participate in whether it's social media campaigns or in-person campaigns, speaking with the media, trying to put out additional guidelines, try to share safety information, those sorts of things in ways that relate to normal people, and share people's stories and experiences, and trying to just communicate that with the lay public as often as possible. Peter Holtz is a pretty active doc on Twitter, specifically about vaccines. I would recommend checking his stuff out. But it is one that is really often leaves physicians just uncertain of what to say or what to do because they've spent so much time studying and trying to make vaccines that we think of as so helpful, that to have somebody really be afraid of them is a little jarring for a lot of people. At this point, my entire practicing as a physician, it's just been part of the norm is that people are afraid of vaccines, and that's just always has to be a conversation. And so anytime somebody comes into my exam room, and the first thing is it's very clear that more people will take vaccines if you just say you're due for these ones. These are the ones that are recommended, and don't ask first. Whereas most of the time we want to ask people their understanding of things. But because vaccines are so important, we tend to do better if we just say these are the ones that we're recommending. Do you have any questions? As opposed to what questions do you have about vaccines before I talk about them? That tends to help people just go ahead. These are the things that are required. These are the things that are recommended for school. There's really quality data for recommendations. As opposed to if we're hesitant about it, people are less likely to accept vaccines. The second is figuring out what people's real worries and concerns are. The Somali population, the Twin Cities, have a huge percentage of kids with autism. And Andrew Wakefield, who had his licensure revoked because of doing fraudulent studies and advertising about a connection between autism and vaccines that doesn't exist. He came in and he spoke to our Somali community a couple of times, specifically trying to discourage them from getting the vaccine. And so within that community, the fear for autism is really prevalent. And it's partly because autism is much more prevalent in that community than a lot of other groups, and trying to figure out why is difficult. And so that is a conversation that I very much engage in about. I recognize that autism's scary, and that you probably know people who have autism and their kids have autism, and they probably didn't in Somalia, because that's the data we have is that there didn't seem to be a rate of autism in the Somali population in Somalia. So why is there an increased rate now in Minnesota? But we've really studied and not seen a connection between the vaccines, and so I really want to keep studying and try to figure out what the real cause is, as opposed to keep putting money into studying the same thing that we've already been able to disprove. Even then, respecting that people make their own choices. So, especially with our Somali community, like that's one where it's like, if you're so afraid, I would rather continue to have a relationship with you and have you come back, and we keep talking.
I think it depends on the vaccine too. Sometimes they might not be opposed to vaccines in general, but there might be one that they're a little hesitant about. Like, yeah. For example, now with COVID, I know a lot of people are going to want to wait.
Yeah. So for example, in the Somali community, most of my patients are happy to get all of the other vaccines, just not the MMR. All the rest of them, just not that one. And for the COVID vaccine trials, like until I see the results myself, I'm also going to be hesitant. Like, is it something that we're going to do like Russia, where we're going to say, let's skip the last bit of making sure that this is really safe and just give it to a whole bunch of people? Like, there's one thing to be enrolled in a study to check for its safety and its efficacy, and there's another to say we're skipping that step, let's just try it. So depending on what we do, I mean, currently it looks like of the main trials that are going with the different vaccines, one of them got halted, but two of them are looking like they may be efficacious or at least safe for about 30,000 people. We don't know how safe that will be for a larger, more diverse population, but yeah, that one's going to be very much an individual choice.
Hi, I had a question. I was just wondering, what would you count as your most defining moment of your career, whether it was in your residency or when you first got out of med school? What was the moment that made you feel like I'm finally a doctor?
There's so many different ways to answer that question. I think the most honest way to answer that question is that it happens really slowly. At this point, like, I understand in my brain that I've been a doctor for 10 years and that's a long time, but I still feel new. I still feel like there's so much to learn and that I'm just never going to know it all. And having a healthy balance of acknowledging your own weaknesses and still being able to continue to go and do the work every day is a balance. And having a group of people that does that as well really makes it worth going into work. If I were around people who were super arrogant the whole time, I would self-doubt myself and not feel comfortable in that group. And so that's part of the people I work with, is everybody's like, huh, that's interesting. That's not what I expected. How do I look that up? Who do I talk to? Like, let's do this together. I remember my first month as an intern, not being a little uncomfortable asking people to call me Dr. Krohn. And I remember about 2 weeks in being like, I just want somebody to do what I said. Can't they just say the doctor said so? And like at the same time being annoyed with myself for that thought. But I would say partway through residency, partly on the fellowship, there was one point in time where there was a story about using 6 months of IV antibiotics to treat low back pain. And I made a face. I didn't try to make a face, but this was presented by one of the producers of, oh, should we report on this? And Brian Williams saw my face and said, doc says bullshit, let's move on. And like at that moment, I was like, yes, I am a doctor in the room, and that does sound like not a good idea. I can look up and see if there's any information on it, but that does not sound like a good idea. Any other follow-ups, Alexis? Did I answer your question?
Oh, no, ma'am. Thank you so much.
Thank you. Next one, did you always know you wanted to be a physician? I tried to fix my neighbor's fish when I was like 12, and he was 6 years younger than me, and he climbed up on his the dresser, and there was a fish tank on top, and the fish tank fell, like the whole dresser tipped and fell, and like the fish tank fell on his face, and he needed stitches, and the mom needed to take him to the ER and didn't know what to do, and called me from next door to come and watch the other kids, and we cleaned up the fish tank and we tried to revive the fish. We did not succeed in reviving the fish, but Richard, he did just fine. He does not look like he has a scarred face today. He did all right. Everyone else survived, just not the fish. But like I was always like bandaging up the neighbor kids. Like, I don't know. So yes, I decided on med peds because I couldn't decide on things. I like variety, I like change, I like difference. But the main reason why I chose med peds is when I was doing my rotations in the hospitals, when I was looking at people who were doing the sorts of things that I really wanted to do, it was constantly med peds people who were just showing up as doing work that I thought was really awesome. And so I'm still sort of surprised that they let me join the club, because they're fantastic. I mean, if you're looking in the news around town, I mean, Nate Chomolo was one of my classmates. He's also med peds. He does a lot of really good advocacy for Reach Out to Read and for equity inclusion. Like he's solid. Andrew Olson was as a med peds doc who helped start Bethesda as a hospital for COVID patients. And I could keep listing people who just do good stuff, and I kind of wanted to be like them. So that's why I did med peds. I met a lot of people throughout my medical training that I like, but it was just consistently a group that I really appreciated. Choosing to be a hospitalist. So the main reason why I ended up being a hospitalist actually is because I wanted to continue to work in Lao. And they actually offered me a position back at the Center for National Health if I was willing to only take 1 month off a year. And I wanted to be able to spend significant time in Lao. So I arranged to be a hospitalist so I could spend 3 months a year. Of course, I then got pregnant. I then got restricted in travel because of health conditions related to pregnancy. And I got my approval to be able to travel again in January of 2020. So I haven't done that part, but that's part of why. Oh, 2020.
Yep, and then COVID.
Yep, exactly. So difference between family medicine and internal medicine. Ooh. They're very similar in many ways, and med peds and family medicine also very, very similar. I really like my family practice colleagues. I mean, my personal doctor is a family practice doc. The training is a little bit different. So med peds is an extra year and it's more hospital time, and you don't do OB, you don't do as many procedures. Family practice, you spend more time in the clinic, you also learn OB, and then you do more like basic procedures. So not like, multiple hour long things, but, and wanting to do global health, I specifically wanted to be able to take care of a wide range of people. And I sort of figured I could learn the procedures because I tended to pick up doing things quickly. But I wanted more hospital training in peds. I think either would be just fine, to be perfectly honest. It's just sort of what you want to spend more time doing. So there's lots of different good groups out there. I know med peds people who also work in northern Minnesota, and they basically share clinics with the family practice docs. So just slightly different training. Advice for people looking for clinical experiences and volunteering during COVID. Oy. No, I wish I had advice.
Online scribing?
Scribing is still possible. So that's always a really good experience. I don't know about online scribing, but it wouldn't surprise me if it exists.
It does. The company I work for, I'm in person at a clinic, but they also have online.
Mm-hmm. Cool. Very cool. Yeah, it's one way there are some research experiences that are still out there. Clinical experiences are more difficult to find at this point in time. I mean, I can't even have the medical student shadow me more than what they're officially required to do, because that's considered too high risk of an exposure. So only when they're assigned to me do I get to have medical students. Whereas before, I would have whatever medical students were assigned to me, and maybe another person who is shadowing me, who is an undergraduate or otherwise. And then for other volunteer things, I mean, contact tracing and getting involved with like Minnesota Medical Reserve Corps, and like the Red Cross stuff, like they're constantly doing stuff for COVID, and that's still clinically related. Minnesota Doctors for Health Equity is another group that you could consider getting involved with. They're constantly looking for other ways to help work with health equity, help improve health equity. I don't know, that's really what I'm coming up with. How competitive are your specialties? Med Peds, particularly at the University of Minnesota, tends to be more competitive than straight Peds, or more competitive than straight medicine, and more competitive than family practice. But not like derm. I don't know if that's helpful. It is one that part of the recruitment programs that I've been a part of, more likely in internal medicine, family practice, med peds than a lot of the other, and emergency medicine more so than other specialties. They'll make a specific point of, yes, we need people to like have book knowledge, but we also need people who can be people and relate to people, and advocate for our patients in a variety of ways. So what you do for advocacy is very important in our application process as well. So not just what your test scores were, but that you know what you're getting into, that you're making a wise choice in choosing medicine, and that you then do other things to help advocate for the health of everybody. That's sort of what we look for. Any follow-up questions on that before I go to the next question? Cool. I see. What does internal medicine mean? That's a really good question. So back in the day, so before the 1970s, you actually had general practitioners. So you graduated med school, you did an internship of maybe 1 year to get your license, studied under somebody, and then you went and you put your shingle up and you could start your own practice or join somebody else's practice. If you wanted to do surgery, you had to do an internship in surgery or residency in surgery, but it wasn't common pre the 1960s to do a full residency programs. Those happened some between the 1900s and the 1960s, but it wasn't like everybody. With the start of Medicare, they established that people should get further training to become specialized. So internal medicine is a specialty as opposed to a general practitioner. But it basically is like you deal with adults and everything on the inside. Like, why it got named that, I don't really understand. Family practice started at the same time. Med Peds actually started 2 years before family practice, but family practice has way more residency programs than Med Peds does. Pediatrics actually started before then. Medical school trains you pretty well to be an internist. It doesn't train you awesomely for being a pediatrician. So when I started, I struggled much more in peds than I did in internal medicine. I was like, okay, the books made sense here. And peds, like, you don't even do the exam in the same order. You do your exam of a kid for physical exam, you do in whatever order they present it to you. If they give you a hand, you start with the hand. If they turn away from you and give you the back, you start with the back. you go with what kids are willing to share, especially the little ones, whatever they give you. Is it hard dealing with children's parents sometimes? I actually generally like dealing with kids' parents. I mean, the good thing in peds is that most kids come with somebody who can help take care of them. Whereas on the adult side, like you're sick and you feel crummy, and you would probably do better if you had somebody who could care for you, but we consider you an adult and you have to make your own adult choices even when you're sick. It's really nice when there's extra family who are willing and able to help take care of somebody, and you're not relying on somebody who's sick to remember everything. Like, it just seems unfair, but it's what we do. So on peds, I love that there's a family member there. It does mean that there's more talking. Like, you have to make sure somebody else fully understands what's going on. But that's probably a good thing. Are there times where family is difficult? Oh yeah. Especially if family is really worried, and trying to recognize that their anger or their sadness or their stress is appropriate. It's out of care for their child. Then that makes that easier to deal with. Just being able to acknowledge it's not about you being mad at me, it's you being mad that your kid's hurt. And we work on that together. That's okay. You get to swear at me sometimes. That's fine. Do I like it getting sworn at? No, but like you're really scared right now. That's okay. Better swear at me than somebody else.
Do you feel you understood better when you became a mom yourself?
Oh yeah, I had one of my pediatrician mentors who was like, "Can you believe we let people be pediatricians without having kids of their own?" And some of the best pediatricians I know don't have kids of their own. That being said, my own understanding of what it's like to have a child is just different. In Spanish, there's two different words for how to say to know. You have to saber, which is sort of like to intellectually know something, and to conocer, which is really like to feel it and to embody it in your heart. And in my mind, it's probably not accurate, but in my mind, it's like to intellectually know something versus like feel it in your bones. And like once you have kids of your own, like you feel it in your bones what it's like to wake up every 3 hours to try and breastfeed for 6 months. Like what it's like to not have slept for 5 hours straight for months on end. And the level of worry and concern, like I brought my son into the ER and I was like, I know it's this. I need somebody else to tell me. Like, I can't do it. I can't do it. He's my kid. My brain is just not working. I just need you to tell me. It's fine. It is hard to be a patient as a doctor. People do treat you differently. I haven't figured that one out yet.
Can you give an example of how they treat you differently when you're a patient?
Well, there's 3 peds ERs in the Twin Cities, and I have worked at all of them, and I am the supervisor for the residents in my hospital. And so when I go to the ER and then I have someone taking care of my child who I have supervised, they're like, "Hi, Dr. Krohn, may I examine your child?" Yes, it is your job. Please examine your child. Please just tell me because I can't think right now. Yeah, it's a little weird.
Dr. Krohn, what is the largest social issue that you have come across that affects the quality of care that you're able to give your patient? So I mean like a greater social issue that prevents your patient from being a good patient, like they may not give you all the information that you might need or something along those lines.
Mm-hmm. Housing and health insurance, probably. I mean, yes. I mean, I have patients who don't have stable housing. How do you keep track of giving yourself insulin if you don't know where you're going to sleep tonight? If your housing circumstances change every 2 weeks, where are you going to refrigerate it? That's hard. That's really, really hard. Access to health insurance. Or changes in health insurance or whatever, if you're on health insurance and you lose your job and now you can't afford your medications, like it doesn't matter how much you and I want you to take your medications, you can't afford them. If your health insurance has changed what is on the formulary, and we know that this medication has worked for you for the past 20 years, but now they don't cover it anymore. Like, that's just real hard. How do I yes. The fee-for-service model also fits into that. Because we're not paid to keep people healthy. We're paid to do as much as we can once people are sick. Whereas what a population, what as individuals we generally would probably want is actually to stay healthy in the first place. I could continue on about housing. You talk about redlining and talk about areas where people have more exposures, talk about asthma in kids and how it's related to cockroaches, and then vicinity to highways as well, that those are all increased reasons why kids get asthma and why they end up in the hospital in the first place. I could also talk about parental leave. I could go on. I could clearly go on. Other questions people want to ask, or should I turn back to the chat? I'm going to turn back to the chat. Difficulties to providing medical care to younger versus older individuals. Try to convince a 2-year-old of just about anything is hard. Like, that's difficult. Trying to convince somebody who has some Alzheimer's to do something is also just hard. Once people aren't to the point where they talk or fight with Alzheimer's, or when they're such little ones that they are just babies, like, you have to deal with them in just different ways. But when they're well enough to be able to argue back, but not well enough to be able to understand, that's probably the most difficult. And that can happen at any age. I mean, yeah, I think of like a 2-year-old as an example. Like, my son does not understand social distancing. Like, he's going to give you a hug when he wants to give you a hug, whether he knows you or not. And trying to get him to not randomly hug people is difficult. He gets upset. He does not understand. And I'll have patients who's like, I'm not going to stop drinking. Like, when I drink wine, it helps my back pain. I am just going to keep drinking wine. And I understand that your cognition score is a 20 out of 30, and that you're not actually understanding the consequences of drinking wine, and that's why you're in the hospital right now, because you fell, because you're weak, because you're drunk all the time, and your body can't handle the alcohol that you used to be able to handle, and that you're going to keep falling because you've broken more bones, and I need to find a safe place for you, and you need to not be drinking. Or a safe place for you where you can drink, which is harder to find, knowing that you're not going to get better. That's all hard. But it's when people can understand what's going on, you have a different set of issues. People can understand that they're sick with COVID. They can understand that they're not allowed to see other people, and it can still suck. I think the not understanding, when people are in conditions where they can't understand, whether that's age or whether that's because of illness, that's hard. That's hard. Memorable experiences. Ooh. So when I was in Laos, I was asked to see a patient who, a child, she had fallen 2 years before from a tree. She had broken her back, and her mom had cared for her for 2 years, wished that she could not get up and walk, couldn't move out of bed, couldn't go to school, couldn't do anything, and was eating less and less. And the family found it harder and harder to feed her, and so she got quite malnourished, and she got bed sores and then infections from the bed sores. And then they got, the mom actually put her on a bamboo mat and dragged her for 2 miles to get her to access to healthcare. And I got to meet her after she'd been in healthcare for several months. She'd gotten food. She'd been growing again. Her wounds had almost all healed. And she'd started to walk again. And then she got a wound on her foot and couldn't walk anymore because of this wound on her foot. And they couldn't figure out what the wound was and why it wasn't healing. And what I was able to do was connect them to a surgeon and an infectious disease doc in Laos, who were the first docs in their country to get the type of training that they had. And I was able to convince the surgeon to not amputate the foot with this wound, that this wound could be treated because of her underlying conditions were thalassemia and then the type of infection, to just get a biopsy of the bone and to present that biopsy back to the infectious disease doc to get a treatment course, rather than amputating her foot. And if I had been there 5 years earlier, I wouldn't have been able to do a dang thing because those 2 people weren't there. They hadn't gotten that training. And they were able to do the bone biopsy, to get an appropriate bone culture, to do appropriate antibiotics there, and do a series of smaller surgical procedures to clean out the wound, that she walked home. Like that's just like, it's awesome. Because it's one, like, I can't necessarily, I can sort of picture, but not exactly, something like that happening here in the US. If somebody fell, they broke their back, they go through things, they get an odd infection, we would be in the exact same boat here about trying to see what we could do to heal it in a way that this girl could participate in life, and keep afoot. But we have all the systems up, and to be able to be part of making that be a system was really cool. That was really cool. Yeah. It's like a lot of the talk about global health work is, are you doing something that's detracting from building the infrastructure there? And so being able to, in that instance, like highlight to other people, like, this is why you built this infrastructure. Like, this is something you couldn't have done a little bit ago, and like, you really did. This is cool. And like, that's the government residency program. That's government fellowship training. Like, yeah, all the way around that one. It's one of my most memorable. And I got to work with all the residents, helping take care of her as she got better. And see them work through the learning process, and to see how sick she was and how better she got, and that's something that they'll all be able to do as they go different places. Because the residents in Lao, we were in the capital city, but they might be the only pediatrician in their province when they finish. Most of the provinces now have 2, but not all. So think about being the only pediatrician for the state of Minnesota. Yeah, they're awesome. What systems does your hospital have for dealing with death or mental health? That's pretty big as far as questions. So we have a palliative care service specifically for in the internal medicine, or for in the hospital as well as outside of the hospital. Most of the hospital systems in the Twin Cities have palliative care. And you can get additional training even if you don't want to do a palliative care fellowship. So that's pretty big. As far as in training for people who don't do palliative care specifically, we do have times in the third and fourth year of medical school where we specifically talk about how do we handle that we encounter death so frequently. One of the big things is identifying what is your role in that death. And so having anyone die is sad, like it just is. But being able to acknowledge that I'm not causing that death, but what I can do is I can walk through with somebody else so they're not alone, either as they are dying or that as they're watching a loved one die, and that is good work and that has value, even if I didn't, fix the underlying medical problem, because probably I couldn't. It wasn't like I failed, it's just that it's impossible. And being able to do the work that helps people just be able to go through those times. For mental health, this is, so I'm not certain, what are you asking? Can I ask you to clarify that more?
And just like, how do you or like your like hospital like help you get like self-care and not like feel overstressed or overwhelmed with like balancing like life and work?
Yeah, so that's fair. I'm a big proponent that I think anybody who's crazy enough to be a doctor should have a psychiatrist and a psychologist. Like, you just should, because what we do on a daily basis is encounter trauma. Like, you're not going to be able to do this work without encountering trauma, and at some point in time you're going to have bystander trauma. Like, it's never going to be the point where you can do this and not have it affect you and do it well. Like, that's just not a reasonable goal. So I encourage anybody to have your own system. We've had conversations about, should we have somebody within our system that for our group we can go to? And we have psychologists, health psychologists who are part of our own division. But many people also don't want to talk about that at work. They want that to be separate. So as part of like me establishing my own providers anywhere was getting myself set up with people who I trust. When it comes to therapy in particular, that's a very trusting relationship. So it is normal, and I tell my patients this when I recommend that they find a therapist. It is normal for you to not like the first therapist. It is normal to take trying to find somebody who fits with the way that you think and the way that you process things. Like, you need to trust your therapist. If you don't, you need to find a new one. And that can take some trial and error. And it's really nice if you can do that when you're healthy before you need it, if that makes sense. Because like once you're already in crisis, then that is like a really raw and emotional time. And yeah, that's when you're getting connected, that's cool, like better connected than not. But if you could do that when you're feeling good and know that this is somebody you trust and can turn to, that's better. So I started seeing someone in med school as a therapist, and I found that very helpful.
Which this brings me to a follow-up question. I see that increasingly people or pre-med students and undergrad are going more towards bachelor's in psychology. Have you maybe seen this helps them in the long run, like in terms of all the material they're given and the classes, maybe how to like help themselves and their patients better? I don't know if you're getting the question.
I don't know if that's helpful or not in the long run to have your own major be in psychology. I had a minor in psychology. I think it is, my focus in undergrad for my minor was on behaviors and how to teach people to do different behaviors. And I find that very helpful with my toddler now. Very helpful. But as far as working as a physician, I find it quite helpful. But I don't think about it necessarily about being helpful for my own mental health. For my own mental health, I need somebody else often to be able to bounce my own ideas off of and to do that process with. I can't manage that all on my own. That's too much on my own shoulders.
Yeah, no, definitely that's not, I guess what I meant, I meant more like in the sense, I guess maybe that it helps you understand a little better and get that help.
I think so. The people that I have, my colleagues who I've seen struggle the most are those who don't feel like they can reach out for help. Whether it's because they think no one else will understand or they feel that they're too busy. But being able to ask for help and be able to state like, these are the things that I need to be whole, that's very helpful in the long run. Stay sane, do your work. Yeah. I actually have, when it comes to breastfeeding, one of the things I talk about is it's really difficult in the first few months of a child's life to feed the child and to get enough sleep. And if you don't get enough sleep, you don't feel sane regardless. And so like step 1 is feed your baby. Step 2 is feel sane. And step 3 is everything else, like take a nap. Just trying to see what your priorities are. If you don't put your own personal health and your mental health first, going through our training process, how we are once we become doctors, how critical we are of our own work, without being able to take time where you stop and check and reflect, you will burn out. One of our Department of Medicine meeting today, the head of medicine specifically spent the first part talking about how when they look at burnout rates, the burnout rates don't change based on the resiliency of the physician. Even the most resilient physicians have a 30% burnout rate. What changes that burnout rate is the organization and the system. If the system is too rigid, if the system isn't responsive to the providers, if the system isn't helping us take care of patients in a way that we stay whole, it's a system illness. It's not a personal illness. So if you're asking about what does my department think as far as mental health of our providers, I think it's really important. We don't necessarily know that we know how to do it well yet. We're still working on that. And we're specifically directed in part because COVID has made the burnout a lot worse.
Dr. Krohn, I have a question for you.
Yes,
To follow everything that you just said, how do you, as a pre-med, as a physician right now, how do you manage to deal with the imposter syndrome? And that adds to that stress. And that, as a mom, how do you don't feel guilty over all the time? I have a 1.5-year-old, so.
I think being a pediatrician really helps me not feel the mom guilt nearly as much, because I spent so much of the last decade of my life counseling parents about how they're doing a good job. This is what I'm seeing. This is normal. So things that my husband, who's not a physician, is like, oh my God, is our kid okay? I'm like, yeah, you're fine. And so I know my child is well taken care of. I know that I'm also very specific about not stepping in when my husband does stuff that's not perfect. I mean, I've taught medical students how to change diapers plenty. You can change your diaper your own way. You can listen to me or not. You're still going to change his diaper, and if you don't do it right, you're gonna learn on your own. That's fine. And to let him do stuff, and to be able to let him fully parent. So I really think there's two things with that. One is that I see a lot of normal kids, and I know my kid fits with being healthy. And so that gives me some distance and some calm with my own child. Second is of being very specific about, I want my husband to be a full parent. I don't want him to babysit my child. I want him to parent my child. So that means I have to let him do stuff his own way, and I have to not step in all the time as if I know it all. I think that's a huge part of it, and that can be difficult. Other than that, acknowledging that I repeat often the phrase, anyone can do everything, but no one can do everything at once. Today, I can do something. I can do anything I want today, but I can only do one thing today. And at this point in time, I can only do one thing and choose the thing right now that's most important and focus on that. And register that I will choose what's most important next and do what I can, and what I cannot do, I cannot do. It's easy to say and hard to do. The next on that is, if you guys have heard of Kay Lane, she's one of the internal medicine hospitalists and does a lot in the first couple of years of medical school with coaching and otherwise. And she specifically says to take the imposter syndrome and turn it around to the con woman syndrome, because it acknowledges that feeling of I don't belong here, I got here by accident, but then it's your own fault that you got there. You tricked everybody else into thinking you should be there. Now you got to keep up the charade. So it encourages me to keep going. And so I acknowledge that feels that way. And then I'm like, yeah, but I am here. And it is here because of my own work that other people believe in that. And that allows me to keep going in a better way, I think. But the other is that the people who I know who are awesome still feel that way. And so recognizing that the people who I see who are doing a really good job, who do really excellent work, they still feel that imposter syndrome. So recognizing that that's an okay feeling, and not letting it stop you.
Thank you so much for answering the question.
Thank you.
My husband is non-medical too, so it's really hard. I agree. It's really hard not to butt in and make him do it my way.
Yeah, we specifically have made points of he sits next to the doctor in the doctor's visits. He is the person that the doctor calls, and he is the primary parent for medical things for Max. In part because as a hospitalist, I'm not going to care until it's way late, because what I see is the bad side of things, and he's going to be much more nervous earlier on. So if he thinks they need to call a doctor, I don't override it. We call a doctor. That is fine.
That is funny. That is a good advice. Thank you so much.
No problem. Wish you the best. Other questions? There's 30 more messages that I haven't even scrolled down to see.
I was wondering if you could speak about, well, if this is applicable, if you faced any hardships in the medical field due to gender biases.
The honest answer is I'm not sure. Growing up in a small town, I chose to play boys league baseball. We had another team that wouldn't even play against us because there was a girl on our team. And so they forfeited rather than play us. When it came down to playoffs and the state championship, they played us and we beat them. And I felt justified, vindicated, whatever that word is. I charged my 8th grade art teacher with sexual assault. And so in comparison, I haven't really had problems in medicine. When I wanted to be a surgeon, I thought that I was going to love the OR and hate the people. And I did my surgery rotation at HCMC, and they swore a lot, but they advocated for their patients and were like, the reasons that they were swearing, I totally understood and I agreed with. It was one where like, this shouldn't happen, blah, 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 bleep, bleep, bleep. This person deserves better treatment, bleep, bleep, bleep. And so I actually really respected the surgeons, and I didn't feel like they treated me differently. Admittedly, the head of surgery at HCMC at that time was also a woman. So just by being female, I didn't feel in my sphere that I had changes or different treatment. When it came to having a child, I did not feel like the system supported women enough through that. And I felt that a lot of the stress and difficulty that I saw in my patients wasn't because the patients were doing anything wrong, but because they were trying to fit into a system designed for a man who wasn't going to be pregnant and wasn't going to be breastfeeding. And so I don't think like people treated me differently because I was a woman, but we didn't set up a system where women can physically be pregnant and physically do breastfeeding. I mean, if you're just breastfeeding for 1 year, that's a full-time job. That's 40 hours a week. And so if you don't have time to set up with that, if you have to see patients from 8 in the morning to 8 p.m. with no pumping breaks, like that's not compatible. But so we've worked on those things. So this year we've had a lactation policy that came into effect for our department. So physicians who work in the clinic get 30 minutes per half day that they get paid for as if they saw a patient if they're breastfeeding. So like, it's just, you have to feed your kids, like just to let you do what you need to do. We need to make our system so it's supportive. And we're working on how to implement that in hospital medicine. So we've proposed guidelines, procedures, and all the fun things, and it's still being worked on. We no longer schedule parents for night shifts within the first 6 months of a child being born. You're dealing with too much sleeplessness already, doing that circadian rhythm to you at that point in time, we just won't do. And again, trying to really allow fathers to be involved. In California, when they made changes to the law for maternity leave, but made no changes to paternity leave, they actually saw that women's involvement at work decreased and their work at home increased, in part because fathers continued to work and not learn how to take care of their kids. Whereas if they had, like Sweden and Norway and some of the other Scandinavian countries have implemented specific requirements that fathers must take time off of work. Like you get 13 months off in Sweden from the age of 0 to 5 years. And at least one of those months has to be done by the father, and you can choose when those months are. So that encourages fathers to actually be involved in childcare and actually at work also advocate for systems that allow parents to be active, effective workers and active, effective parents. I can clearly talk about that a lot too.
I think, I'm not sure if it was supposed to end at 4 or not, but I guess since we're getting towards the end, what advice would you have for those of us applying to medical school now that feel maybe we might not be, I guess, having imposter syndrome, basically? Yeah,
so you're applying to med school not because you already have the skills to be a doctor, but because you want them. Like that's fair. And acknowledging that you're not perfect now and you won't be ever, but that you want to get access to these skills to do this sort of work. That's fair. What most medical schools want to know is, are you making an informed choice? Are you choosing to be a doctor because you want to and because you know what is in store? So if you haven't had experiences with medicine, with what that world is like, getting those experiences is some of the most important, and COVID makes that real hard right now. The other, and that's really, the other is like, can you do this work? Have you demonstrated that you can do something well? And that other something doesn't have to be bench research. If you have worked with a community organization to help get a nonprofit off the ground or help them to accomplish X goal, that takes an incredible amount of commitment. If you play an instrument, I mean, I tried to play saxophone and I don't really. Like those sorts of things, like those are, you show that you can commit to a difficult task and do it. If you can take that same sort of energy and apply it to wanting to serve patients well with an informed choice that you want to help make other people's lives better by being able to understand the difficult aspects of science and how to relate that to another person, like, that's a solid application. Just make it you.
Thank you so much.
Hi.
Hello.
To continue with that, so say you did work with like people recovering from like alcohol addiction and things such as that. Do you think that would be fair to put as on your application or
Oh my
no?
goodness, yes, please. Like seriously, yes, please. That is one of the hardest things for people to do, is to work with people who have an illness that we specifically stop treating when they relapse. I mean, the cancer comes back, we do more chemo. Alcohol, someone relapses, we're like, well, now we can't do those things that we talked about previously. Like, it's really hard. So having experience actually working and engaging with people and treating them as human when they go through that, that's huge. That's huge.
Thank you.
Thank you very much for your work. I'm not getting to the other 34 new messages.
Dr. Krohn. Oh, sorry.
Yep. As I'm scrolling through them, I see most of them are just kind of their reactions and I think just how much they're getting from the session. So as we're coming down to the end, I don't know how much more time you have, but I think we're down to like the final, maybe like 1 or 2 questions before we end this. You can just say them out loud if you have them.
Dr. Krohn, if you have clinical experience that's not technically with a physician itself, like I'm a certified nursing assistant in a long-term care facility. When I'm writing, for example, a personal statement, or for anyone here that has clinical experience, it's not always directly with a physician. If we write it from a point of view of we get to see the integrated approach to medicine with everyone, with all parts of the care team, what would you say that would be sufficient for most medical schools?
Easily more than. To be honest, if you're a certified nursing assistant, you've done more of the dirty work than I ever have. Like, and you still want to do more and to serve patients more. Like, holy cow, thank you. Like, that's beautiful. It is one that I feel like our certified nursing assistants, like, they're the ones who, for the most part, like, actually take care of patients. Like, I sit and think about like a lot of it, but if they didn't exist, like often I joke about like, if I was on a desert island, like what would I want with me? And I'm like, nurses and help, because all I know how to do is like put orders in the computer. Like the actual care part is so often delivered by other people.
Thank you very much.
No problem. One of the questions that will come up often for people is why go for a physician versus a nurse? Why go for an MD over a physician's assistant or nurse practitioner? Everybody's involved in the care of people. And in my opinion, the question is, what is most rewarding to you? If what is most rewarding to you is to be able to have that emotional relationship with people and provide the active hands-on caregiving, often nursing may be a better choice. If part of what you really like is that thinking about how the body works and the science behind it and making those decisions and being involved that way, then an advanced practice provider, an MD, may be more appropriate. if you want to be the one in the end making decisions, then going for the MD makes sense. If the idea of being the last person people turn to is terrifying and you don't want to be in that position, then maybe being an APP may be more appropriate. So I like, as particularly before I became a physician, I really like to be the one to like have a final say in things. And so I really wanted to be a physician. Now, some days I still would really appreciate to phone a friend when I'm in that circumstance. And I get to, I mean, I'm at a large university hospital. Like there's always somebody else I can talk to. It may mean that I have to be humble and register that I'm asking for help, but like you're rarely alone. My physicians in Lao, like they'll send me a Facebook video going, I can't understand this one. Like even though they're the only one in the province, like there's still a network. You can still ask others for help.
Okay, well, thank you, Dr. Krohn, for coming and staying much longer than you had to. We appreciate it, and I think this has been one of the most informative and helpful sessions. So thank you so much, and thank you everybody for coming.
No, I feel like so much of what we look for in people who are applying to med school is that people have an idea of what they're getting into. And I think the questions you guys have asked have all been really, really well rooted and show that you have an idea of what you're looking towards doing. So that's awesome, but not being able to do the shadowing, not being able to get some of those experiences right now, like we all feel for you. Like none of us know what it feels like to be in your shoes, but we register that this is hard and different than what we experienced. So thank you.
Thank you so much.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.